Okay, I think we're going to go ahead and get started. I hope you are hearing me well. First of all, good morning, good afternoon, and good evening to you all, wherever you are in the world. My name is Walter Suarez, and I am the chair of the Hl7 International Board of Directors, and it gives me a great pleasure to welcome you all to our 34th annual plenary and working group meeting. These are truly unprecedented times we're living in, and I am hoping that you all are, first of all, staying healthy and keeping safe. And for the first time in 34 years, we are holding our entire event this week through our new virtual platform. So I hope you will be engaging, participating, and enjoying even our virtual cookie breaks, just as if we were all together in the same place. So let's get started. This week, we're going to have actually not just one, but two plenary sessions. The first one will begin momentarily, and the second one I just wanted to mention will take place on Wednesday between 3:45 and 6 p.m. In the U.S. Eastern Time. So let's go ahead and start with our opening plenary event. Today, I'm truly honored to introduce and moderate an international plenary that will focus on leveraging Hl7 standards in the time of COVID. And it is my distinct honor as well to introduce our speakers. I will introduce them all very briefly, and then we'll go to our first speaker, and I'll introduce them in the order in which they will be presenting. So first of all, we have Bernardo Mariano. Bernardo is the Chief Information Officer of the World Health Organization, where he is responsible for coordinating WHO's digital health vision and strategy. He leads and oversees all aspects of information technology, data security, and enterprise application, ensuring WHO is advancing its digital capabilities to deliver its global health goals effectively. Prior to joining WHO, Mr. Mariano was the Senior Regional Advisor to the Director General of the International Organization for Migration, where he was responsible for strategic oversight of IOM activities within the Sub-Sahara African region, and advised on emerging trends and developments, including regional and national policy initiatives. Bernardo will be followed by Professor Renato Sabbatini. Professor Sabbatini, the CEO of the EduMed Institute for Education in Medicine and Health, and the co-chair of Hl7 Brazil. He is a biomedical and computer scientist with a PhD in physiology. And in addition to that, he is an entrepreneur, technical and business consultant, university professor, and prolific writer. His specialties include international and national consultancy, strategic planning and business and plan development, telemedicine and telehealth, medical and health informatics, video conferencing, satellite data, and video communications, and a number of others. Bernardo will be, Professor Sabbatini will be followed by a fireside chat that our CEO, Chuck Jaffe, will hold with Amy Abernathy. And Dr. Abernathy is the Principal Deputy Commissioner of the Food and Drugs at the Food and Drug Administration in the United States, where she helps oversee the agency's day-to-day functioning and directs a special and high-priority initiative that cut across offices overseeing FDA's regulations of drugs, medical devices, tobacco, and food. As the acting Chief Information Officer, she also oversees the FDA's data and technical vision and its execution. And Dr. Abernathy is a physician, hematologist, oncologist, and palliative medicine physician, an international recognized clinical data expert, and a clinical researcher. And last but not least, Chuck will also hold a fireside chat with Ken Goodman, Dr. Goodman is founder and director of the University of Miami Miller School of Medicine Institute for Bioethics and Health Policy. The Institute is a WHO collaborative center in ethics and global health policy, one of 12 around the world and the only one in the United States. Dr. Goodman is the co-founder of AMIA's Ethical, Legal, and Social Issues Working Group, and his research has, for nearly 3 decades, emphasized ethics and biomedical informatics, and in public health and epidemiology. His most recent book of Ethics, Medicine, and Information Technology, Intelligent Machines and the Transformation of Healthcare, comes from the Cambridge University Press, and is a prime example of the work that Dr. Goodman is doing. So as you can see, this is an incredibly powerful and international opening plenary, and so it is truly a pleasure and a honor for Hl7 to host our guest speakers this morning. So we're going to go to Bernardo for his presentation or remarks.
Thank you, Walter. Good morning, good afternoon, good evening, depending on where you are. It's a great pleasure to be here, and it's a great pleasure to also, through this presence of WHO in this gathering, in this meeting, to show the level of commitment, support, collaboration that we want to see it happening, but also we want to see it going to the levels that were not there before the pandemic. The COVID-19 pandemic might seem very unprecedented, but many scientists, many researchers had predicted that earlier. It predicted that we would have something that would shake the world on healthcare, on health side. It's true that through the pandemic, we witnessed a great response from the private sector, from all the public sector, academia, to come together and provide those digital solutions that we all need. Digital solutions that can complement the public health response. We saw contact tracing, chatbots. We saw cross-sectoral collaborations. We saw many other tools that some of them matured, some others yet to mature, but that were brought forward to deliver the response. So we can move a few slides, please. Two slides from there, please. Yes. So how do we move with the pandemic? The question was, how can we accelerate actually some of the things that we started earlier, prior to the pandemic? Understanding that healthcare sector is behind many other sectors on the digital transformation. And the siloed nature that doesn't help. So, but also that at WHO, the digitalization of guidelines was another area that we knew that it needed acceleration. We were already planning before the pandemic. So next slide, please. But let me, as I talk about WHO guideline, let me perhaps give you just a snapshot of the process. So we get evidence from countries and we start preparing a guideline. So just the fact that we have to get evidence from countries to prepare a guideline, it already shows you that if we don't have the evidence, we can hardly prepare a guideline. Of course, we have guidances when we don't have evidence to make sure that we can still respond to emerging issues. But the pathway of producing a guideline today is very long. But let alone the ability to actually use the guideline in a digital ecosystem in a way that we can update sections of it. So a guideline is produced in a document, and as it goes through a whole process, all the way to ensure it reaches the national level, becomes a national policy, gets to the health workers and health services, the populations benefit from it. It is a long journey. It's a journey that might it takes too long in such a way that some parts of the guideline can actually even be already slightly outdated. And then to restart again, we have to restart for the whole guideline. So smart guideline and digital guidelines, it's something that we believe that as WHO, it is a global digital good that we need to bring to this ecosystem to ensure that that we bring integration, we accelerate the production of the guidelines, but also we can update quickly, and we can create a feedback loop from the user all the way back to the guidelines to make sure that we keep them updated constantly. Next slide, please. So for Minister of Health, and in today's situation, we have a situation where guidelines or digital guidelines or digitized guidelines are in a way a product of either one sector or one particular vendor or one particular university that took some of the content that we produce at WHO and digitize them. But we want to make sure that we work in a collaborative way. We basically complement each other's strengths as we have the strength to bring guidelines together by looking at evidence from different countries to put together in a guideline. How can we leverage on technology to have a quick digitalization of that guideline? How can we make sure that we have a quick update? How can we use Hl7, FHIR, and others to really bring that interoperability that we all need to ensure that we all benefit from it? So today, guidelines, because of time, might not be accurate by the time it reach the public. There's of course the issues of trust, let alone the privacy considerations, especially with the fragmented health data ecosystems. But it's not cost efficient, not coordinated, and the list is long. So as we go for smart guidelines, as we digitalize the healthcare sector, in considering the pandemic, we owe to the whole community the need to deliver products, services, and content in that digital ecosystem that brings and impacts positive health outcomes. And for that, we need to work in a different collaborative scheme that were better than before, and not the same one that we had prior to the pandemic. Now, because I don't want you to just hear about these high-level topics that or issues that I'm bringing forward. I'm sitting here with Garrett Mell, a scientist at WHO, who will dive a little bit deeper down into some of the works that we're doing in this area. So next slide, please. So as we have to remember that a digital ecosystem addresses perhaps the need and can reach slightly more than 50%. I think it's 52% nowadays. So 47% of the world still is not connected to broadband. So we have to keep that in mind. But also we have to make sure that the digital solutions are an integral part of the public health response, because that's how we can see the impact. And within that perspective, the smart guidelines for us is where we will take WHO to the next level of where we'll create a WHO where in that digital ecosystem we can create a framework that allow countries to either share data or use artificial intelligence and other technologies to really bring that positive health outcomes. Now I'll pass the mic. We don't have one, but the one that is you're using for you to listen to us, to Garrett, Garrett Mell, who's a scientist who will dive in a little bit more on the smart guidelines. Garrett, please.
Great, thanks so much, Bernardo. Next slide, please. So smart guidelines are what Bernardo had mentioned is an approach we're taking across the organization at all levels to augment the way that we release clinical public health and data recommendations in guideline form. And at their heart, smart guidelines are leveraging standards, standards that you love and know well, including HL7, but also value sets, ICD, LOINC, and others, as well as operational recommendations and requirements that ensure that the translation of a guideline recommendation is done in a way that preserves its fidelity and ensures that it can be taken up quickly with digital systems. Next slide, please. I'll talk a little bit about how we get there. And with work across the organization led by Bernardo and the science division, I'll talk a little bit about the stepwise approach that we're taking. Next slide. We have been working with many colleagues, including colleagues in the HL7 community, to look at work that had been done before by Baxwala and others, and really looked at the framework that Baxwala had developed to determine how the guidelines on the left side, the L1 narrative text, could be operationally translated into requirements documentation. So structured data sets, ensuring that workflows are defined, personas, decision support logic is framed in a way that those who are operationally looking at how they can bring this content into digital systems can communicate and talk to the experts in the domain area, like an immunization expert, and have a conversation that's well-informed. So that they can determine the changes that might need to take place at the country level or on the basis of the system they're bringing those requirements into. We looked at how we might ensure that when it is translated into a digital system, that it's machine readable and in a consistent way. So we really looked at the work that that is represented in an implementation guide and ensuring that those standard terminologies are established, and look to see how we might leverage standards that were emerging in the HL7 community, like CQL, that could be used to indicate how indicators should be calculated, and also how decision support would be supported in a consistent way. We looked at and have really wanted to ensure that the executable applications are reflective and are not a watered down derivative, but rather are reflective of the intentions of the recommendations in L1. And then of course, as we move forward, we recognize that the data that will, and the evidence that will come out of the use of the guidelines will inform and through AI and machine learning can be optimized against prioritized outcomes and brought back as evidence back into the guidelines process. Next slide. Next slide, please. So we recognize this whole portfolio, the L1 through L5, previous slide, is not actually recommending a specific software application. It's not bound to a specific application. It's standards-based. It ensures that it's neutral to which software the solution and the recommendations brought into. And it also empowers ministries to have a say and the ability to be part of the localization and part of the digitization process. It's really a set of generic components applicable to any system, but it's a minimum set that we as WHO recommend, and recommend in a way that's reliant or is aligned with the recommendations that we provide in our clinical public health and data recommendations. Next slide. We see the maturity of a country going through from paper and using Excel into really transitioning into using standards and ensuring that they can leverage and augment their systems with AI and machine learning, and ensuring that they are part of a learning environment of using standards. We're very excited about that. Next slide. I'll briefly just give an example of our work in this area around antenatal care. There were 49 recommendations released in 2016 from a traditional evidence base and review, and we determined that it would be valuable to go through this process and determine to what extent this is a replicable approach across WHO. Next slide. At the L1 level, you see specific recommendations and their narrative, and they're often subjective to interpretation. And so it's critical for us to ensure that that subjectivity is not lost into the next, into bringing it into digital solutions. Next slide. And L2 provides that operational format in which the minimum data sets, the workflows, the personas, the decision logic is defined in a way, and using other standards like BPMN in a format that is consistent in how it's interpreted by engineers. Next slide. L3 really is, I think, the bread and butter of the HL7 community, and really reflects on the different components that are reflective of an implementation guide. From our perspective, we want to ensure that we're using value sets that are going to be free and accessible to member states of WHO. So we're doing our best to ensure that we leverage free ICD and other value sets. But we're also leveraging CQL for decision logic and calculation of indicators. Next slide. And we want to ensure that we have an ecosystem that's supportive of the communities that are going to be part of this work, both from the translation of evidence into guidelines and all the way down to the users at the health workforce and ministry level, but also that we have the ability to ensure that the translation between L1 and L2 and L2 and L3, et cetera, are consistent with the intentions of the guideline recommendations, and that there's an ecosystem of services, whether you're deploying on a mobile phone or whether you're wanting to leverage through an API and a framework, and whether you want to use a consistent terminology set. We're trying to make available these services that would help facilitate the adoption of this Smart Guidelines work. Next slide. I want to thank you all. Bernardo?
Thank you. Thank you. Walter, over to you.
Yes, thank you so much, Bernardo. We are going to go to our next speaker. And I just wanted to mention too, this work that has been highlighted regarding the development of WHO guidelines in the digital age. We're very honored to be a part of and work in partnership with WHO and others in helping develop and advance this important technology effort. So very much appreciate that, and we'll continue to look forward to our joint collaboration there.
Thank you.
Let's go to, yes, indeed, thank you. Let's go to our next presenter, Professor Sabbatini. So Professor Sabbatini, please.
Okay, well, thank you very much for the invitation. I'm very much honored to be here with you today. I work with Hl7 Brazil since a decade, 10 years, more or less. And Brazil is a really interesting case study because we are one of the 3 hardest hit countries in the world, together United States and India now and Mexico. We have almost 150,000 deaths. And there was a need for urgent activity in technological segment of the response to COVID-19. And this had to be done exclusively at a distance, remotely. Well, I have already been presented about medical scientists by an origin. In regard to Hl7, I have been a founding member of Hl7 Brazil. I'm a co-chair and director of education, and also a founding fellow of the International Academy of Health Science and Informatics. My agenda today will be a shortly overview of demographics in the healthcare sector in Brazil, to those who don't know, an overview of the pandemic and what were the technological initiatives, mainly the National Health Data Network and the Connected SUS project, and also a little bit about telemedicine during COVID-19. And I finalize about talking a little bit about Hl7 Brazil activities and summary conclusions. Well, Brazil is, for all standards that you have, is a big, big country. We have the fifth largest country in the world by land area, 8.6 million square kilometers. We have the sixth largest population, 210 million inhabitants. And we are the ninth largest economy, with a gross national product, 1.9 trillion parity purchase dollars and $70,000 per capita. In terms of Latin America, we are the largest population, largest area, and largest economy, representing about 65 to 70% of that. Politically, we are a representative, federative, constitutional republic, a democratic US-like presidential model, but by means of direct popular vote throughout. And our Human Development Index is considered high, 0.739, but our Gini index is not very good. The language is Brazilian Portuguese. It's the only country in Latin America that speaks Portuguese. Considering healthcare demographics in Brazil, is the second largest healthcare sector in the Western world, second only to the United States. We have more hospitals than the United States, more beds, and more primary care units, and have about 500,000 physicians. And we have the largest number of medical schools in the world, 327, graduating about 27,000 physicians per year. Our system is a mixed one, combining public health, which is universal, decentralized, comprehensive, by means of the unified health system, which was created exactly 30 years ago, and is the largest in the world. Dataset is the Ministry of Health Data and IT division that is in charge of taking ahead the new digital health strategic plan, and our healthcare expenditures are around 9% of the GNP. 7% of the population is poor and does not afford a healthcare plan, so they are dependent on SUS. And 25% use the private healthcare system, the majority of them, 98%, through healthcare plans and insurance, group medicine, and medical odontology were cooperatives. These cooperatives are a particular Brazilian model. For instance, Unimed is one of them, is the largest private healthcare system in the world with 18 million beneficiaries, 115,000 physicians, and 140 hospitals. I work also with this system nowadays. Our general life expectancy is good, 77.4 years in 2020. Regarding COVID-19, is a tragedy actually, because we are among the three largest in the world. We have 4.5 million confirmed cases, and almost 4 million have been recovered. 136,000 attributed deaths to COVID, with incident to 2,000 cases per 100,000. 65 cases mortality per 100,000, a 3% lethality. And nowadays we are decreasing rates, as you can see by the graphs, with 747 rolling weekly average of number of deaths. The federal government and the state governments have invested very heavily in trying to combat COVID-19, as you see here by these numbers. And the good thing is that we are now in phase 3 testing of at least 3 vaccines, AstraZeneca, Oxford, China, and Russia, and 200 million doses are assured by 2021. So we hope that we can eventually achieve good numbers when vaccines are effective and working. Regarding IHT policy, timeline in Brazil is long. We started 30 years ago with the creation of Dataset, as I said to you, is Department of Informatics of Ministry of Health. And this progressed through committees and national policies of information and informatics, eventually achieving its zenith in 2011, when Brazil was the first country in the world to nationally adopt mandatory adoption of 12 interoperability standards, including Hl7. including also SNOMED CT, LOINC, many others. And now, of course, in 2008 2009, we started a general digitization of the healthcare in Brazil with DigiSUS, ConnectSUS, and RNDS, which is a national health data network. I intend to talk a little bit about that. So all this has been accelerated enormously during emergency legislation during COVID-19. A snapshot of technological initiatives in this area, the federal government had already in place a very good epidemiological information networks and services by the way of Anvisa, which is a mix of FDA and CDC like in Brazil. The National Health Data Network using Hl7 FHIR standards. The ISUS AB, which is a primary care electronic health record, which have been implemented in more than 60% of all of the 41,000 primary care units in Brazil. The ConnectSUS, which has information access infrastructure and access for the public health services. And immediate centralized COVID lab tests mandatory notification already working. Patient and provider management portals, patient-facing apps like you see here, okay? And also telehealth network with active monitoring calls to monitor symptoms. They made almost 40 million telephone calls by an automatic system to investigate how was symptomatic COVID was present in the population, and a COVID patient information app. So we have also many other initiatives by state and municipal governments and the private health. I don't have time to talk all of them then, but I can assure that there are many. So starting with the RNDS, which I think seems to be the most important initiative in digital health so far. It aims to promote a nationwide electronic health record for the exchange of information between the points of Brazilian healthcare network, thus allowing the transition continuity of care the public and private sectors. It is more or less the Canadian Health Infoway model, okay? RNDS is meant to be so an Infoway for complete health data through interoperability health information standards, but it's not meant to be a front-end system or a centralized electronic health record for all citizens, or even a database. It allows us to connect all the players and stakeholders in the healthcare system in Brazil, which is very large, as you saw, including regulation, including populational health, care programs, pharmacies, emergency services, healthcare units, CMOs, user communities, and so on. It's a very ambitious program. It's still underway. Current model of health data interchange in Brazil is quite chaotic. It doesn't use a interoperability bus or whatever, it uses web services mostly, where you have the information generators on one side and the information consumers in the other side, and information flow is unidirectional. So the vigilance, epidemiological vigilance is such a kind of system with multiple stakeholders. What Brazil intends to do is a model that uses information generators and consumers on both sides, and information flow is going to be bidirectional. So RNDS works like effectively as a bus for interchange information, a health information exchange at the national level. Its main features is that it's able to incorporate legacy data. It is federated. Its concept uses data containers at state level, which are nodes, so it's distributed system. It's native cloud-based and scalable. It's open source and mobile friendly, using several new technologies for all open operational systems. Its exchange of information, good for us, right, is based entirely on Hl7 FHIR and JSON, and also implements blockchain for security, persistence, traceability, federation, and non-repudiation. There is a requirement for consent, user consent and data protection, which is compliance to the general law of data protection, has been recently became enforced in Brazil yesterday, right? So consent is very important. And it uses nationally standardized document templates and a reference information system, which is called the CMD, a minimal health data set. It uses the concept of BFF to integrate all levels of access to devices, which is the backend for front-end architecture. And the minimal health data set is the official reference information model in 2018. It's mandatory for all levels of healthcare. It addresses management, financial, clinical data sets, and unifies dozens of previous documents and templates and forms and standards. So this is already being adopted, as I saw in RNDS. RNDS architecture is very complex. I don't intend to explain minimally what is that. Don't have time for that. But you can see in a macro way that we have consumers and generators information this side. We have databases from the health care here and other federal database here. And all the containers have at least information services and technological services, right? So in blue, you have planet services still not implemented. But in a summary, the architecture elements we have are very complete so far. In terms of information services, we have network regulation, epidemiological vigilance, notification, clinical documents and images, discharge and CCR documents, electronic prescription, care episode management, and several databases, including immunization transplants, and has a very good system for audit tracking and data analytics. On the side of technological services, we have MPI, already in place since 5 years now, which uses the profiles, IAG profiles, PICS and PDQ. Terminology services, HR services, minimum data sets, BFF services, consent eligibility, blocking, sharing, fire messaging, and also it is prepared for clinical decision support and telehealth services. This data protection and privacy is a particularly concern of all the developments that we are doing. It's entirely based on a requirement. This is all information can only be accessed when authorized by the owner of the information. In Brazil, the citizen is the owner of all information about him, not only identity, but also demographic and clinical sensitive data. So before starting to use the system, the citizen must consent to the access to his or her private data, is informed consent. The consent term is validated and stored in the system and provides rules for controlled access to identification in clinical data. And the own patient can also access his or her own data, right? So one important thing in Brazil, we are very advanced, much more than the United States and Canada and other, in terms of the best long-standing mandatory PKI, public infrastructure for standards for digital certificates. Mandatory digital authentication and signature using this digital certification, using open standards like XML, and healthcare related electronic documents. It accepts 3 media types, USB tokens, smart cards, and cloud-based. And physicians are issued digital license IDs, like you see here, okay? And a chip with their digital certificate. So it permits paperless full transition to paperless and digital hospitals in EHR systems, and allows for physical media discard after scanning and digital signature. So it's working now and provided by laws that regulate all that. And it's also included into the Brazilian EHR system certification requirements. Connect SUS is also a very interesting project. It allows access to any citizen to his or her personal health information, as have been recorded by all the public and private organizations, including pharmacies, labs, radiology, etc. It is based on the unique ID. It's called the National Health Card Number, CNS, are also in our IRS fiscal number, which is called CPF. So it connects to service-oriented architecture and PDQ standards for identification demographic data. And it's connected also, as I said, to National Health Data Network bus for healthcare data. Includes secure access and data protection using blockchain, digital certificates, and encryption. It is in construction also, right? So far, COVID lab test results and full immunizations are already being provided through these applications, patient-facing application, as you can see here. It has also the provision to add an Apple Wallet. You can buy things like airfare and access all your digital information regarding COVID, regarding vaccination, and so on. Here you see the access to vaccination, not only COVID, but others as well, and provides a certification vaccination for all citizens. It has also a professional-facing application. It promotes access to information among professionals from different points of the healthcare network, allowing the transition continuity of care in the public and private sectors. The ID is provided through also a central record of all healthcare entities and professionals in Brazil, which is called CNAS. Well, there are many RNDS benefits, as you can imagine. Everyone that has worked in such a kind of interop system can attest with a better access to health information, a complete recording of health services and data, and the patient's trajectory, a greater diagnostic accuracy expected, and higher, better resolution, speedy resolution of cases. Organization of information is going to be much better, including monitoring, telehealth deployment, and eventually also more advanced applications like IoT, medical IoT, and enhanced data quality. Well, finalizing this explanation, tell you briefly about telemedicine during COVID. Brazil is the largest telemedicine user in Latin America. Brazil has since 2005 two large federal-sponsored telehealth programs in all states, with more than 30 hubs and 2,000 remote sites. One is called the Brazilian Telehealth and Primary Care Network, and the other is University Telemedicine Network. And it has increased, of course, its activity a lot during the pandemic. Because of the pandemic and the inability of patients and physicians and other healthcare providers to meet in person because of the quarantine and restrictions in mobility, exceptional legislation has been passed by all the houses and several agencies, allowing for emergency teleconsultation directly with the patient and physician and other healthcare professionals, and electronic prescribing for healthcare specialties using digital signatures. The private sector, as expected, has expanded its telemedicine activities enormously. And now there are more than 50 new companies offering telemedicine platforms in Brazil, including several ones from abroad. Hl7 Brazil has been very active through all this. We have several working groups: education, interoperability, certification, technologies, continuity of care, electronic prescription. We are in development of the FIRE-BR core, Brazilian core implementation guide. We have a page of Hl7 Confluence. We have also already published many resources, profiles, and bundles. And in this year, in December 20,000, we are going to provide, to offer the first Connectathon for patient and lab results, and others have been planned for 2021. I am particularly involved in all of this as education director, and also I am the promoter of RNDS CDS hooks and cards info button standards for CDS support. And there are several consortia of companies being formed just now. And we're not only limited to Hl7, we integrate with other standards like OpenAir, LOINC, SNAMED, CTI, CD11, etc., because there are no Brazilian affiliates of those institutions and standards in Brazil. Our educational program is very large. Education Working Group has offered 33 courses since 2011. We have our own LMS platform and services. Today we have 100% distance education. And we provide the translation of Portuguese of HL7 official electronic learning course. And now, since May, also the HL7 Fire Fundamentals online course of 5 weeks. Introduction to Health Information Standards, CDS HL7 Standards Workshop, and other courses as well. And we have so far more than 600 graduates, okay? I am responsible since its inauguration in 2012 of the entire program. And also we have a national international CICS webinars. This has been provided under the directorship of Mariano Abrão, which most of you know very well. In fact, he is sending his greetings to you. He's still recovering from COVID, but he's going very well. And we hope to this week to make a special ceremony with the presence of Dr. Hammond in a homage of what Mariano Abrão has represented for HL7 Brazil all the time. He's also a fellow, right? And so you see here many important names from the HL7 from Brazil and abroad that have talked in our international cycle of webinars. In summary and conclusions, my dear, is that as elsewhere, Brazil has experienced a large growth in digital health in this, due to the pandemic needs, particularly in the public-private and interchange, EHR and telemedicine usage and regulatory activities. We have progressed more in 6 months than in 10 previous years. That was the pace of acceleration that we have experienced. It has been a tremendous boost to HL7 in Brazil, and it's occurring without historical parallel, in large part due to the federal government mandates and adoption of FHIR and other standards, as I told you, since 2011. The change have a high chance to persist, fortunately, and to expand after the COVID pandemic due to its perceived benefits by all people that have experienced it. And the digital network infrastructure in Brazil is the most advanced in Latin America, including 4G, and now in the next 3 months, 5G, LTE, wireless, cable, optic, as well as digital certificates. And so the National Strategic Plan for Digital Health is actually accelerating very well its pace of implementation. And it's a long-range plan, of course, and Brazil, with such a large population and large territory, is harder to implement than the smaller countries. Thank you very much for your attention, and I hope to answer questions that eventually you have about my presentation. And here you have my contact information. Thank you, Walter.
All right, thank you so much, Renato. It's been a great pleasure to work with you and work with the HL7 Brazil affiliate. Our thoughts and our best wishes go to Mariano as well. I had a chance to hear him last week. He's doing, as you mentioned, much better. So that's great news. And we look forward to hearing also from him as soon as he continue his path to recovery. So appreciate very much your presentation. For everybody, we're using the chat on the Whova application for any questions. So if you want to send questions for Bernardo or for Renato, please do so via the chat. We'll have a chance to have some questions at the end of the event today. We'll reserve a few minutes for those. There is actually one that came through that might be applicable for or might be directed to you, Renato. It says, do you use or do you plan to use FHIR to store or communicate consent, patient or consumer consents? What can you tell us about that?
As I showed to you, the BFF format and the advanced web-based applications they use the same infrastructure regarding communication. So far, FHIR is being used only for notification of lab results. But in the near future, let's say in the next 6 months, is going to be used also for clinical documentation, for immunization, for notification of immunization adverse effects, and also is being used to provide to patients all the information they want to know that is stored in the whole RNDS system, okay? So this works as a messaging system, not as a storage system in the terms that is going to be a huge database. It's more like the Canadian model. Everyone has its own healthcare and EHR infrastructure and stores its data there. If you need the data, you provide a link to this data using FHIR standards and FHIR URL RESTful models. And this has been implemented since the very start because all the developers who worked in that in 2018, they recognized it, fortunately, that they didn't have to create their own standards. Because, you know, in the world of standards, everyone wants to create their own standards, particularly governments. And so it was very nice that the new director of Dataset was a very experienced fellow, Jacques Barros, and he worked with many standards, including Hl7 standards. So he provoked that government would have to adopt FHIR Hl7, although other Hl7 standards are used too. For instance, V2 and eventually V3 has been used in Brazil for a very long time now, but not as has experienced the same diffusion as Hl7 FHIR as we have. Just to give you a brief example, when we started the first fundamentals FHIR course, which was in May, we had about 120 applicants. And of those, 80% said they have immediate use for that, immediate application for FHIR. And FHIR was not a very well-known standard in Brazil. It was thought of as a very new standard. But this showed to us, and now we are in our second course, is that the demand is very high to understand better interoperability standards based on the Hl7 model. Okay? And this is very good for us. We're very happy with that.
Excellent. Maybe a couple of quick questions also, Renato. One is applying the FHIR capabilities to the research environment. Any perspectives on that?
Okay. Oh, it is planned in the RNDS infrastructure also to be accessed by research and education institutions, right? So far, we have none of that because we still have to publish all profiles and bundles and slices that are being used. But one thing that we want to do is an area that I'm trying to work with is clinical trials, okay? So for instance, we're doing a very large clinical trials for the 3 vaccines that Brazil has acquired through contracts. The Russian one, the Chinese one, and Oxford AstraZeneca one. No American were involved in so far. And these traditional vaccines that are working very well, they have hundreds of thousands of people involved in phase 3 trials. And these phase 3 trials are not being communicated at all. So one of the things the government wants to do is to have also use FHIR to provide communication of the results of these trials, including now you can do this now only for tests. You can using LOINC and using COVID codes in LOINC, you can provide actually mandatorily, you can provide the results of PCR and serological tests. The government so far almost 5 million tests have been communicated. And see, this is a huge database that is being used by the government to access how the COVID-19 is going and so on. So it's natural now that all the COVID vaccine trials also should communicate their results also to the RNDS. And this is going to happen. Actually, is the next step of the development is going to be a connection to research trials.
Excellent, thank you. And Bernardo, if you're on, there's one question for you as well about creating test case and formal expectation for systems. Question is, does your process see the need of creating formal test cases and establishing some formal expectation for systems?
Okay. Well, one point.
Actually,
okay,
Renato, that was I think that was the question directed to Bernardo. Mariano.
Oh, okay, okay.
Bernardo is still. I don't know if Bernardo, if you're still on.
I don't know.
Yes, I'm still on.
Yeah, it looks like that. Yes, you are. Okay. Hi, Bernardo. Okay. Yeah, so I don't know if you heard the question. It was about the process for creating formal test cases and establishing some formal expectation for systems with respect to that.
Yes. Our chief scientist in the whole science division is working on that. It's called the Solidarity Trial. So to ensure that we really accelerate the clinical trials of vaccines and medicine in general. But yes, there is a whole consortium with a multi-stakeholder led by our chief scientists working on that. So we are using the pandemic to accelerate also some of the processes to deliver reliable, I would say, therapeutics and vaccines as we go. It's just part of this ACT accelerator, which has a co-sponsorship with a number of heads of states and including endocrinologists as well. So yes, we are working on that.
And maybe another one for you, Bernardo, if you don't mind. I know you're working on the global strategy on digital health for 2020, 2025. How do you see this development of the clinical or the WHO guidelines and the use of FHIR fitting into that strategy, which is, if I understand it correctly, is looking at helping countries advance digital health in their own respective environments?
This is very much an area that actually we were lucky that the fact that the global strategy in digital health was actually in the final stages when the pandemic was declared. Then we took additional consultation with the member states to really make sure that the global strategy on digital health speaks also to the actual pandemic, on how can we adjust, how can we use FHIR, and how can we use the standards to make sure that we add value to the whole digital health ecosystem. So we had a number of inputs from our member states. And we had 2 consultations just during the pandemic, so which really allowed us to bring the global strategy into the real situation of the pandemic and how we can use this to accelerate the implementation or the transformation. It's true that it's one thing having a strategy, it's the other thing have the implementation, and it's the other thing has to see the real impact. So we are very cognizant and very aware of that, the need of not just having a strategy for the sake of a strategy, but to see the implementation of the strategy, but also at the end to see the impact of that strategy in the health population in general. Thank you.
Excellent. Thank you so much, Bernardo. We look forward to working with you on finalizing and certainly, as you point out, implementing and measuring the impact of that strategy. HL7 International will certainly be very much on your side in helping the deployment of this very, very important global strategy. So thank you for that. I think we're going to go to, yes, indeed. I think we're going to go to our next portion of the this opening plenary. I invite Amy to join us now. I think she'll be able to, hopefully she'll be able to turn on her video screen, and I will also ask Chuck to join us as well and start this fireside chat with Amy. So welcome, Chuck, and welcome, Amy, also. Thank you.
It's a real pleasure to be here. Thank you, Walter. Those were more remarkable presentations, and I think the opportunity that we have to expand the reach during this pandemic is a testament to the combined efforts of so many people. So thank you, Renato and Bernardo. Our next discussion will be with Dr. Amy Abernathy. Amy's career has been a long and storied one. Our paths even crossed as oncologists some years back. So my first question really, Amy, is that your move to the FDA was a significant career step for you. What motivated you to join the FDA, and how does that mesh with your work at the agency?
First of all, thank you very much for inviting me. It's an honor to be here with you. As you mentioned, I am an oncologist by background, was at Duke where I was a professor of medicine and was the founding director of Duke's Center for Learning Healthcare, where we were working on this issue of how do you build systems of interconnected data to simultaneously run clinical trials, do observational research, and get information to point of care. And then following my time at Duke, I went to Flatiron Health in New York City, a health tech company, where we were looking at how do we build these kinds of data sets now from the perspective of being a software and computer science company. And what I learned both as an academic, but also in the health tech space, is that certainly the policies, the regulations writ large are fundamental to moving the entire space forward as we think about building a learning healthcare system, as we think about how do we make sure that we make maximal use of interconnected data. So after I had decided to leave Flatiron Health, the role at FDA came available, and it just made perfect sense to extend that footprint. I joined FDA in February of 2019, and just sort of as a backup to remind everyone, the FDA as an American agency regulates about 20 to 25% of the US economy, but certainly our regulatory actions have a global impact on economies all around the world, and also significant role within the context of managing public health. Our responsibility is to protect and promote public health by regulating medical products, food, tobacco, and other products such as those in the veterinary and cosmetic spaces. And we also promote public health by promoting the development of new innovations. And I ultimately came to FDA because it very much aligns with my focus on learning healthcare systems, as well as patient centricity and the concept of how do we really work towards using the totality of the evidence. The last thing I would say is I'm Principal Deputy Commissioner at FDA, but you probably noticed that part of my title is also Acting Chief Information Officer. And when I came to FDA, I realized that if we were going to continue to push forward on learning health systems and with this issue of how do we use data in smart ways, it was really critical that we focus on the technical underpinning of the FDA. And so in September of 2019, we announced the Technology Modernization Action Plan and those activities.
The Technology Modernization Action Plan will be a game changer for the industry, but it will also impact so many aspects of medicine in America. Could you expand on that plan?
Absolutely. The plan had its birthday on Friday of last week. So we are exactly 1 year into this plan, which really has 3 core components. The first is to modernize how FDA's technology is built and used using a cloud forward strategy. And it means that we not only need to make sure we have the right computers and the right focus, but we have to make sure that we have the right organizational structure and culture for a more modern tech forward and cloud forward FDA. We need to make sure that we have brought in the new kinds of capabilities and plans for new capabilities that align with that. So for example, planning towards better use of data and artificial intelligence. So that's part 1 of the plan. Part 2 of the plan is a focus on doing by showing. So the value of use cases to demonstrate both inside the agency as well as across the industries that we regulate what is possible, and help to identify what are the core capabilities to be built inside the agency and also across the entire ecosystem. And I'll come back to an example in just a moment. And then the third part of the plan is really to open up the communication channels with the data and tech industry writ large in ways that we have not done in the past, really to be creative about what's possible. An example of the use cases that are sort of driving as we build our cloud forward strategy. One example is 7 and 15-day safety reporting. So historically, if a new drug or new biologics application is submitted, an IND for the study of a new drug or biologics is submitted to the FDA, and that product is under study, then there are safety reports that get submitted on 7 and 15 days. You often might remember from your clinical practice the MedWatch forms. And those forms are submitted to the FDA electronically, but really as digital paper. And one of the use cases that we've been working on is the submission of 7 and 15-day safety reports via an API, so that it's structured data being submitted to the agency directly, and now structured data that's ready for data visualization, more efficient evaluation for safety signals, et cetera. And that use case prepares us for what is the cloud forward environment we need to have at the agency, as well as what are our capabilities that are needed with respect to APIs and also data and analytics, and then also prepares the industry for where we're going with respect to moving towards structured data.
Well, personally, that's a relief to hear. How does the data modernization link to this effort that you're describing?
So in September 2019, when we put out the Technology Modernization Action Plan, at the very end, there was this signal, a couple of sentences that suggested that once we worked on our technical underpinnings from a cloud forward point of view, really what this was pointing us to was how we were going to think about using data differently in the future. And in fact, that pointed the way, so that in January of 2020 at the Consumer Electronics Show, we announced that this was the year that we were going to start working on our data modernization strategy. And we had our kickoff meeting in June of 2020. The data modernization strategy is in preparation, so watch this space, and I anticipate that you'll see a fuller document coming out soon. But to give you a bit of an early signal, we expect this strategy to parallel our technology modernization strategy. So it will highlight the things that we need to do as an agency to make sure that we're using data in the most modern and efficient ways. So governance, data characterization and quality, a focus on structured data, a focus on having capabilities that allow us to use data efficiently, as well as it will incorporate a focus on use cases. So use cases that showcase what it looks like when we put data to work, And then also a focus on what's the talent we need inside the agency as well as across the ecosystem to put data to work. So watch this space.
As a principal investigator, I was always struck by the fact that when we submit information, it's just a snapshot in time. There's a continuity of data that's related to the entire life cycle of patient care and clinical research. How does your plan propose to manage to that target of having data continuity?
Really important. And first I'll sort of back up and hit on the point of our plan prepares us to think about data from sources that we have historically not focused on, including the electronic health record. Our plan also allows us to start to think about the fact that we imagine medical products and we evaluate medical products not just at the specific point of market entry, i.e. when they're FDA approved, but we also think about those medical products across their life cycle. And so importantly, moving to a space where we can have more continuous evaluation of medical products, such as devices or drugs, as they continue to be used across time. And so importantly, as we think about the need for data sets that allow us to understand how medical products are performing across time, we need to be able to bring in data that's reflective of longitudinal care. And so that means we need to become more and more facile with how we use novel data sets, including electronic health record data, patient-generated health data, and others. And so practically speaking, we need to learn at the agency how we're going to use those kind of data sets. One example that I've often thought about is, as the agency, we need to get as comfortable as possible with the integrity of a data element that traverses through the electronic health record and then makes its way to FDA for review. And how do we understand the full life of that data element from the point of collection by the clinician or other person in interfacing with the original technical systems to the points of ultimate data extraction, abstraction, and what other processes are taking place that then ultimately transmit it into the final data set. And as an agency, we need to get comfortable with all those steps along the way. This is also going to be become critical as we think about new ways of using data sets such as hybrid trials, where it's traditional clinical trial data collection using traditional prospective case report forms and other mechanisms, now married with passive data collection through electronic health records and other means that are appended to the original traditional clinical trial data set to provide longitudinal late effects monitoring. And so those kinds of capabilities I see as coming, but first we've got to get very comfortable with how we use those data sets and how we can ultimately trust them.
It had to come about that real world data would be part of this process. I'm certain that the COVID experience has dramatically accelerated that. Could you comment on how electronic health record data is impacting the decision-making process and data collection for real-world evidence?
Absolutely. So first I'll do is define real-world data and real-world evidence, and then take that and apply this into the context of what we're seeing in COVID-19. So as we talk about real-world data and real-world evidence at FDA, what we're talking about are data that are collected outside of the context of a traditional clinical trial setting. The goal of real-world data and real-world evidence is to provide more generalizability, so reflection of populations who may not have been studied in the traditional clinical trial, as well as to help to understand elements that are relevant to everyday clinical practice, but may not be a part of traditional clinical trials. And as we think about the data sets Specific for real world data and real world evidence, we're talking about electronic health record data, claims data, patient-generated health data, including patient-reported outcomes or information from biosensors, including such as a watch. We're also talking these days about social listening and social networking data and other types of data sets that start to fill in the full context of the experience of the patient and the experience of health. So that's the sort of language of real world data and real world evidence. In 21st Century Cures, and the 21st Century Cures Act passed in December of 2016, FDA was compelled to evaluate the role of real world data and real world evidence in two specific use cases: post-marketing commitments and requirements, so studying a medical product after its FDA approval, as well as label expansions, so secondary indications. And FDA has been working on guidances for real world data or real world evidence in that frame. And in December of 2018, we put forward a framework that said that in order to use real world data, real world evidence, we need to understand what data sets are fit for purpose, what analyses are appropriate and fit for purpose, and the use cases within which we can use these data sets. So that's the backdrop. And so FDA has been very actively working on this real world data and real world evidence space enter the pandemic, COVID-19. Suddenly we were in a place in February and March where there were so many questions to be answered and so much work to be done, and frankly, an urgency without the time to do all of the work for every clinical trial that we would need to answer and address every specific question. And so for that reason, we dug in hard to trying to figure out how can we confidently put real world data and real world evidence to task for COVID-19. In partnership with Reagan-Udall Foundation and Friends of Cancer Research, we kicked off the COVID-19 Evidence Accelerator, which is a real world data community to address COVID-19. FDA is an active participant and provides technical expertise, and we have over 600 participants from across the country, and really meetings that happen every week with over 150 individuals in most of the meetings. And the idea is to bring health technology companies, data holders, health systems, government, nonprofits, academia, and others all to a common space where we're figuring out how to address COVID-19. The Evidence Accelerator has brought to the table a series of tools, such as common research questions we're all trying to address, common data elements for COVID-19 that we seek within the different data sets, translation tables between common data models, so being able to, for example, translate between OMOP and CDISC and other common data models. We also have different forums and mechanisms for investigators to work together quickly to address the questions relevant to COVID-19, and a series of master protocols and common analyses that different teams are running, which is allowing us to figure out this science quickly. It's been interesting. You know, I always say that we're working on writing the living textbook of COVID-19 right now through real world data. And practically speaking, we're trying to understand the natural history of disease. We're trying to understand whether or not drugs that were already being used for some tasks could be repurposed to help treat COVID-19. We're trying to understand, for example, patterns of care and what does that do with respect to the medical product supply chain and risk of the development of drug shortages or device shortages or PPE shortages, and how can real world data help us figure these things out. The science is hard, but the teams are working quickly to address this space. And I really see that COVID-19 is the place where electronic health record data is really being put to task, and we're figuring out in real time what we can and cannot do with these kinds of data sets.
Side question, as a principal investigator, I was always struck by the notion that the prospective clinical trials often provided a narrow focus, often missing large populations that should be included in a clinical trial. Do you envision that the real-world clinical trials will be able to expand that vision so that the data that's collected is more representative of the general population, or certainly the at-risk population?
That really is, I think, the fundamental goal of real-world data and real-world evidence. How can we use lessons learned in broader populations than those studied in clinical trials to understand the performance of a medical product in populations that are sitting right in front of us within the context of the clinic? A couple of important points that I think underlie your question. First, real-world data and real-world evidence can be retrospective or prospective. So pragmatic clinical trials with broad eligibility criteria that enroll broad populations are indeed prospective real-world evidence. And pragmatic clinical trials, the data sets can be filled in using electronic health record data. Might be a mechanism to allow us to better understand a medical product being used, for example, in the elderly individual or the person who has multiple comorbidities, and certainly the person who traditionally doesn't enroll in a clinical trial. Also, retrospective or passively collected data sets that already exist in electronic health records and are being curated and cleaned up, these can be used to help us understand, for example, how a medical product that has already been studied in a clinical trial now performs when being used in larger populations. One question a lot of people have right now in the context of COVID-19 is, can we start to understand patients in the United States who are getting corticosteroids in a way that mirrors the recovery trial from the UK, as a way of saying the UK's recovery trial demonstrated that dexamethasone helps to treat the person with severe COVID-19 in the hospital on oxygen. Are we seeing similar patterns in the United States? And also, what happens when it's other corticosteroids such as methylprednisolone or cortisone being used as opposed to dexamethasone, as we saw in the recovery trial? So these kinds of questions can now start to be evaluated in broader populations, very much as you described from your experience being an investigator.
One of the challenges that we always face is that there's a tiny subset of clinicians who participate in clinical trials because of the tasks required to become a principal investigator. Do you see that this effort will expand the population so we have a more representative group of clinicians who are reporting to the FDA?
That's a really interesting question. You know, I can't, I don't have a crystal ball, so I can't see the future, but my hope is that many of the lessons learned in the context of COVID-19 is going to essentially democratize the process of being an investigator participating in clinical trials, as well as being a patient participating in clinical trials. And let me give you an example. You know, one of the areas that's always been hard is that clinical trials tend to be attached to specific sites where there are primary investigators and also the ability to deliver investigational product to that specific site. Now with COVID-19, what we're learning is the use of remote monitoring as a way of monitoring patients who can't get back to that site of clinic, as well as the safety or not of having investigational product be able to go to clinics beyond that single site. Those two things together will help us understand essentially the ability of clinicians in many different areas beyond that usual primary site to be able to participate in clinical trials, and what that does to our ability to help keep patients safe, as well as have high quality data sets that can answer the question at hand. And one of the tasks going forward after COVID-19 is to step back and do our due diligence of understanding with detail what happens to both safety as well as data integrity, so we can understand which of these regulatory flexibilities should persist after the pandemic. And so that's how I think that we may ultimately democratize more participation in clinical trials. And I see a lot of other examples as well.
I just want to editorialize for a second and can't imagine that after the experiences of the COVID pandemic, we'll ever be able to turn the clock back entirely. So with that, let me ask you one more question, Amy, and that is, within the context of building a learning health system, how does EHR data fit into the evolutionary role of the FDA in the modernization efforts?
You know, I think we're all notionally striving towards building a learning healthcare system. I don't see it as one particular, you know, united system, but a series of microsystems that become progressively more united through data, and specifically interoperable data. Ultimately, the electronic health record is a critical foundation for us to get there. With the advent of the HITECH Act in 2009, really, it helped to take this country into a landscape where electronic health records are a fundamental undercurrent of how we deliver healthcare in the United States. And certainly that is also similar around the world. If we're going to build a learning healthcare system, then we need to be able to leverage the data that lives and exists within our electronic health records. We need to be able to have it in structured formats that we can ultimately extract and harmonize and analyze quickly. We need to be able to understand or characterize data so that we understand its quality and how to ensure it's fit for the analytic purpose and task. And we need to also make sure that we enrich data sets with other data sets. So for example, information from the electronic health record enriched with laboratory data or with patient-generated health data to tell a more complete story, so that we're ultimately building on that vision of a learning healthcare system. I think FDA has a very central role in this story. This is actually part of the reason I came to FDA, because FDA helps us with definitions of what does good look like? How can we have confidence in data and data integrity in order to address high risk questions such as the approval or evaluation of a medical product? And understanding that then also helps us understand data sets that are derived from electronic health record and other data to be able to put to other tasks within the context of our learning healthcare system. Last thing I would say is that in this notional concept of our learning healthcare system, the same data can be put to use for multiple tasks simultaneously. And that's actually one of the beauties, that we can use information to understand how to take care of the patient sitting in front of me, understand the quality of the healthcare delivery, solve for operational tasks, solve for clinical evidence development tasks, and also continue to monitor things across time. And the more that we use data, the more we put it to task, actually the data quality improves over time, because the only way you can improve data quality is to first put data to use and understand how it performs and what we need to do to upgrade it. And so that's, I think, one of the key features of a learning healthcare system is to use the data, and that will help us improve it for the future.
Amy, we've had lots of questions, but there's one question that I think deserves an answer, and that is a question from the audience of where can we learn more about the FDA's efforts, potentially to get involved, but certainly to learn more about the many things that you addressed this morning.
Thank you for asking that. So the Technology Modernization Action Plan is on our website. If you just Googled FDA TMAP, you will find it quickly. We are having a series of public meetings. We had one on June 30th, and we will announce another one soon. And these public meetings are an important opportunity for you to have a voice in our data modernization strategy and how we're doing this work going forward. And then also, I encourage you to think about participating, for example, in the Evidence Accelerator, which you can find out more at evidenceaccelerator.org. And if there are other things that are exciting to you, I also encourage you to just get in touch with me directly. We always want to hear from you.
Amy, as always, it's a pleasure. Thanks for taking time out of your busy day to participate. It's a pleasure to have you at HL7. So thanks again. Walter?
Thank you.
Thanks, Amy.
Yes, Amy, thank you. Indeed, it was a great fireside chat. Lots of questions. We will be posting some of the websites and links that Amy and Bernardo and Renato and others have mentioned on the Whova app. And now I think I'm going to turn it to Ken and Chuck for a second fireside chat. So please, Chuck and Ken, go ahead. This will be the time to jump in. Thank you.
Good morning. Despite Walter's introduction, Ken has been an enormous supporter of HL7 over several decades, really contributing to the meaningful changes that have taken place within our organization and in the standards community at large. So I'd like to open this up by just asking Ken, where does standards fit into the world of ethics? You wrote a whole book about it, but could you enlighten the audience?
I suppose reading from the book now would be inapt. Chuck, thank you very much for this opportunity. It's a privilege to be able to continue that collaboration. What I've spent a fair amount of my time doing over my career is reminding colleagues that when we're interested in ethics, we are not, riding around with a horse and a sword hoping to smite evildoers. That the core values of ethics, the core utility of ethics has to do with helping people solve problems. It's not about saying stop, slow down, don't do that. It's very often about how to guide colleagues in saying, here's how. And so when it comes to standards, what I think the organic connection is palpable, that if your values are improving well-being, reducing suffering, managing disease, improving public health, and so forth, those are values. And if there are tools to improve the support of those values, I'd argue we have an obligation to use them. And so ethics and standards are related and they're connected at several points. The anastomoses, if you will, are numerous. Here's one. Standards are in some sense about consistency and regularity. You might even say, given our newfound interest in this through the NIH, in reproducibility, that if consistency cannot be achieved, then the goals that we sought, all those values I mentioned earlier, are not going to be realized. That we need, for the sake of health, wellness, public health, to be able to get it right as often as possible. And the likelihood of getting it right, in my opinion, and I think this is uncontroversial, has to do with tools to ensure consistency. You mentioned clinical trials a number of times, Chuck, and I want to say that when we do a randomized controlled trial, actually is done according to certain criteria or standards, if you will. If you think of a standard as an agreed upon method to ensure consistency, the connection between standards and ethics, I think becomes really quite clear. That's at large granularity. At finer granularity, what the standards are, what they should address, how they should best do that, raise a number of ethical issues. Our colleagues online from WHO and the FDA are keen to figure out how it is that we can use health information technology to improve the health of populations. Now, that is easy to say, and as we all know, really difficult to do. If you bake ethics into the process at the beginning, you will prophylax, I believe, against further problems, unintended consequences, unexpected objections, and perhaps even failures of reproducibility. So I see standards, it's almost as if standards are a tool of ethics to try and achieve those shared goals.
From a perspective of shared goals, what is the underlying principle of ethics that unites the two, standards development and ethics?
Great question. In fact, one of the things that we say in ethics is something that is said commonly in the standards community is there are sure a lot of principles lying around, but I think there are several and we can articulate them easily. And I think that they draw really nice bold lines between the two. And they're also common and I think uncontroversially, universally shared values. The first is transparency, openness, sharing. It wouldn't work very well to have a secret ethics plan or secret standards, right? None of them would work very well. These are about communities of people with like interests. And these might be in no particular order, but after transparency, let me list accountability. Namely, if I'm going to be writing code, or I'm going to be developing a policy, or if I'm going to be using electronic health record to connect to a randomized trial, then we need to make sure that those of us who might be doing that are going to be governed by certain standards for being able to take responsibility for those actions. Accountability and responsibility are obverse sides of the same coin. In other words, I need to own what I am developing and be able to take public responsibility for it. The third one that I like listing most frequently is related, I guess, to transparency, but it's veracity. Namely, that we have a duty to tell the truth, that deception of various sorts, and there are many ways we can figure out how to deceive each other, is actually going to be inapt when it comes to realizing those goals of improved healthcare. Learning healthcare systems, for example, any effort to develop them is going to be impeded at the least and derailed at the worst if our data sets are not accurate and true. If the way we share them is not by means that will build confidence in veracity. We've seen this, by the way, and this will be a question I hope you ask in a little while. We've seen this in full color during COVID-19. Absent transparency, accountability, and veracity, well, one, you lose public trust, and two, you don't do as good a job as you could have done managing a pandemic. That applies in daily clinical practice, it applies in daily research, it applies in public health emergencies.
Well, that foreshadowed the next question that I was hoping to ask you, which is how has the pandemic brought the marriage of standards and ethics to the fore?
It has done, in my opinion, more than many events in the last several decades to do precisely that. For example, those of us who had the job of trying to develop crisis standards of care for the pandemic, that is to say, if we don't have enough ventilators or we don't have enough remdesivir or convalescent plasma or whatever corticosteroid you're looking at, that we've already, or looking forward, enough vaccines, then we need some credible evidence-based value embodying guidance to make sure that when we allocate these scarce resources, we do so in a way that is fair. And there the values of transparency, accountability, and veracity matter a lot. Those crisis standards of care, for example, for ventilator allocation, needed to take into account, well, patient prognoses, they need to take into account comorbidities. If our goal is to save as many lives as possible, that's an empirical question. And we have a lot of data that shows what interventions will work most effectively for what kinds of patients. Throw in, by the way, some precision medicine, and you can see in passing the important role of genomics and genetics. In those crisis standards of care, almost all of them that were developed included sequential organ failure assessment scores, or SOFA scores. Here's a well-known informatics tool, one of several prognostic scoring systems that were used as part of the effort to identify which patients and which patient populations would benefit the most from, for example, ventilator availability. a lot of people who saw those standards had never heard of SOFA scores before. A lot of them never knew that there were informatics structures that undergird all of the things that, well, for example, that we've been talking about today and that HL7 has been working on for nearly 4 decades. Namely, how do we write the code that best achieves these goals? By what process is that code vetted? How do we protect privacy and confidentiality along the way? And so when people were saying, well, what are these computer programs that are helping me decide who gets a ventilator? I think we've seen in boldface a really exciting opportunity to expand awareness about the importance of health information technology in general, or biomedical informatics, and public health crises. That everybody knew about their electronic health records, which raises a separate issue, as you've identified. We need to remind our colleagues that we've been working on trying to work with the EHR community to make these better. And now we're working with the public health informatics community to try to improve the tools that are being used to make really difficult institutional and clinical decisions.
It seems to me that the exchange of data between electronic health record and a public health agency is almost an ethical question. How do you raise the level of importance of this capability to the bring it into the sight of people who have to make these decisions?
That's a really,
that made you sigh. I'm sorry.
No, everyone who says that's a good question, what he means is that's a really hard question. But I think I have an answer. Look, I know, and I think most ordinary people know, that I am better off, that me, Ken Goodman, my health is better off because people I trust have analyzed your information and Renato's information and Marianne's and Mark's and Walter's and Dave's. I'm looking at names on my screen. In other words, the history of public health science has been collecting personal information for the benefits of communities. So if we can get it right in terms of privacy, so that all that data is metabolized in such a way that we can all benefit from each other's, without, for example, saying that Ken Goodman at 123 Elm Street has a left big toe malignancy, then what we've done is we've shown how we share in our community lives responsibility for each other. And the beauty of it is I can share my information to benefit you at no cost to me. The tool for doing that is the electronic health record, especially as electronic health records include more information from surveillance and surveillance and wearable devices and all the apps people use, and increasingly genetic and genomic information. I am confident that there are plenty of adequate, if not excellent, security and privacy standards and protocols, some of them developed by HL7, to help me be comfortable in knowing that people I trust are using that information to benefit others, knowing exactly at the same time that that information is going to benefit me, benefit my family, and benefit my community. It requires an awareness of the very goals of public health, namely that I don't, how shall I put this? I, of course, for our purposes today, have no political opinions whatsoever. But anybody on this call who finds themselves dispirited that some of our compatriots, I mean world citizens, believe that wearing a mask takes away some precious liberty they have, I would suggest that there is no such liberty that any of us has to increase the risk of health maladies to other people. And therefore, if I want to contribute to public health and in turn benefit from improved public health, then I need to be able to one, trust the systems in place, and two, be willing to share my information through my EHR to trusted people who are going to use it. The role of standards in this, I think, is absolutely crucial because they help build trust. What we're seeing is an erosion, if you will, in trust in certain public institutions. And I think our work is cut out for us in shoring up and expanding that trust. Because as a matter of fact, one, if we all wore masks, there'd be less virus. Two, if we all were able to share our health information in trusted systems, why there'd be less death, suffering, and lack of wellness around the world. And so those are the ways you link these two things up. You remind people of their enlightened self-interest. And enlightened self-interest not only includes benefits, it includes some obligations.
Enlightened self-interest is a interesting topic for an entire half-hour discussion. But when it comes to standards, there's really a critical pivoting point here regarding sharing your data, consent, and the opportunity to support the common good. How has that impacted your role as an ethicist at the University of Miami?
So one of the things that we've been able to work on is the ability, for example, to query EHRs to identify, for example, possible participants in research. It used to be that was a really difficult thing to do, but fortunately, through changes in NIH and other regulations, and some of these we're advocating, by the way, to the World Health Organization, it is possible in a secure environment to permit people who are appropriately authenticated to be able to query EHRs to do a number of different things. One of them is to identify particular participants. There are, for example, under local, national laws and international standards, provisions for public health that will allow my de-identified information to be used to support the common good. Once again, parenthetically, it would be perverse of me to say, no, I just really don't want you to use any of my information, de-identified and managed in systems by people I trust to help other people. That would be perverse. It would be ethically perverse. And so what we have now is an opportunity, and what I've been able to do a little bit at Miami is point out how the requirements of valid consent are not being compromised at all when we allow trusted people to use information. We've done a lot of work lately in what's been called latent or tacit consent. Public health authorities have relied on this since, oh goodness knows, probably at least John Snow, who famously during the cholera epidemic in London in the 19th century did something no more complicated than putting dots on maps where his patients lived, and was able then to identify the source of the well that many believed the cholera was coming from. He didn't ask their permission. He didn't give them a HIPAA form to fill out. He didn't give them a consent form to put a dot on a map. And I hypothesize that none of them would have minded. The point here is that when we do this in a way that is transparent and trustworthy, what we gain are the benefits of an improved shared public health system, but we haven't violated the expectations of consent. Public health has relied on the tacit consent of communities. If someone says, I don't want you to use any of my data at all for anything, what we have then is not somebody who's exercising a right. What we have then is somebody who's become a free rider on a system. You might liken it to vaccines. We've decided in most of our jurisdictions that your putative right not to be vaccinated does not exceed my bold-faced right not to be sickened by you. To be sure, we are seeing now controversy surrounding that, but I believe most of those are examples based on ignorance, ideology, and certain perturbations in our social fabric, which I am optimistic will pass away one day.
You've touched upon the concept of implicit consent. How can HL7 respond to strengthen that concept and to provide the underlying standards to reinforce that? Because it's really critical in a public health environment and certainly in today's pandemic climate.
Well, I started to, in some sense, I anticipated that a little bit. One is history. that when HL7 does that, it's not making this up. This is not our collective first rodeo. We have a long history of using information. Everything we know about public health that really matters, ranging from car seats to helmets to the efficacy of certain drugs, has been based on health information that was used without someone signing a piece of paper. The FDA regularly collects and analyzes information through the Sentinel system and otherwise about drugs and devices that have produced adverse events. So we have a long-standing history in all our jurisdictions. This is true in Latin America, this is true in Europe, this is true in Asia, and it's true in Africa, of using people's information without their permission. Think of it simply, when we think of surveillance, for example, sometimes we just need to know in a particular community or village that the number of people with influenza or HIV or cancer increased by 1. If I'm that 1 and you change your number from 200 to 201, why then you've used information about me, right? But it would be perverse for me to say, I don't want you to increase your number by 1 because that's information about me. You see, the point is that we have this idea of health information, including all the details of my medical record. And even if it includes all of those, once you strip away enough identifiers, that can be really adequate for robust standards development. So history is 1. 2 is best practices. Anybody who knows about missingness in biostatistics or the other ways in which we have, let's relate to the problem of reproducibility. All of the circumstances in which we've gotten it wrong has either been because of a failure of data or a failure of method. Standards link those two things by making clear that we need to have both in order to get this right. And so you have a sort of a process or a method justification. History, methods, and the third one I think is shared values. That when you need to do this at HL7, this is not edgy, this is not controversial, this is not, while the standards may be cutting edge, the principles underlying it are not. The principles are common sense shared value standards that have been tried and tested for many years in many different jurisdictions. Public health would collapse tomorrow if we could not count on that kind of role of implicit or tacit consent with appropriate controls and appropriate governance. That's part of what we're working on, what I've tried to work on at my institution in Miami, and what my institute has worked on with our colleagues at the WHO, which now has a special working group on AI and machine learning, developing a program in global guidance. You've heard how difficult it is for the WHO to get something approved through member states. I'm inclined to think, well, you think it's difficult there, try and get it through my institution. Part of this is human nature to want to make sure we're doing it right. And sometimes adoption requires nuance and information that people regard as trustworthy. But that's what HL7 can do. History, best practices, and shared values.
Glad you circled back to AI and machine learning. Clearly, the technology is approaching whereby we'll be able to face the mountain of data head on and provide conclusions. But after all, the algorithms that were implicit in developing the AI systems were human generated. I don't see a methodology to skip that step. I won't ask you to be a futurist right now, but from an ethical perspective, how do you address that?
So, I could be a futurist. I think we're all futurists, right? But some of us are more utopian than others. We're doing what we do. We have put our shoulders to the wheel. HL7 has all the organizations of people who are on this webinar now, I think, share the value that we want to reduce suffering, extend life, reduce disparities. An important point to make along the way, because the ethics community is trying to contribute to that as well. We want to make sure, one, that our algorithms are not biased, and that our attempt to use informatics tools in resource allocation don't discriminate against minority populations or people with disability. getting the algorithms right. One might involve actually helping computers write better algorithms. The back propagation algorithms that are available haven't changed a whole lot in a very long time. They are modified by humans, however, and what I think we're evolving toward is a world in which that code and efforts to write and improve that code and to maintain and build and maintain the databases that you train your algorithms on need to be governed by, well, transparency, veracity, and accountability. We need to put in place nimble governance mechanisms that do not impede the science, but help build trust among the people we say we're trying to help, that these systems are going to improve their healthcare. And I think that's possible for algorithms in machine learning. Those of us who've been working in machine learning for years have known how tricky it is to get it right and how easy it is. Well, for example, you write a machine learning algorithm and I write a machine learning algorithm to solve the same problem. If we get different results, one, we've had a problem when it comes to reproducibility, but two, we've learned something really important. It's something that we need to learn that feeds into that governance component. What standards attempt to do is ensure quality and safety. And those, I think, those values are essential. They undergird other values as well. I mean, the reason we want to be transparent, tell the truth, and be accountable is to improve quality and safety. And if we can do that with an appropriate and nimble form of governance that is smart about consent and smart about privacy, then I think that we can look forward to a future in which these intelligent machines will actually help us in ways that we will all be gladdened by.
There are a host of questions, but there was one that really struck me, which was that HL7 as a global membership community reaches out intermittently to the ethics world for engagement. But how can we as HL7 members be connected to the University of Miami community or to a larger ethics environment so that we can stay abreast of the kinds of thinking and processes that are really critical to your success?
Well, when you began, Chuck, you mentioned how long we've been collaborating. Our communities, the standards and ethics communities, have in fact been approaching, I think, what a good answer to that question might consist in. What can we do to fledge, foster, and support to sustain a more robust attention to standards in the ethics community and ethics in the standards community? A number of ways that we've done that has included, well, our interactions, for example, this one, through our shared organization, AMIA and INEA, there are ethics working groups in both of those. I think I blurted out the interest in WHO, which has been working with the University of Miami to work on machine learning, AI, and other informatics issues. Why don't we make that an agenda item for next steps? How can we in fact do this? And Chuck, maybe you and I can work on a follow-up webinar on something that would precisely do that. Let's work on a working group to have a working group on how we can better link ethics and standards. I think the foundations are there. They're long-standing. They're among colleagues from around the world. Once again, I was delighted to see some of them. Renato is still on the call. We met 25 years ago. By the time you and I, Chuck, met, we are colleagues of long-standing, and I think we have an opportunity here to do something really exciting, to signal that the utility of applied ethics is going to improve standards, improve the missions of organizations like HL7, and in fact provide educational and professional development opportunities for people around the world.
So before I turn over to Walter, let me say thank you so much, Ken, for your time this morning and your decades of contributions to this field. Thanks to Amy for her participation, and Walter, your show.
Thank you. Thanks, Chuck, and thanks, Ken, again, for such a wonderful session too. Well, this has been an exceptional way to really get us started with our first ever all virtual plenary and a work group meeting. Many thanks again to our amazing speakers, truly an international group of very thoughtful experts, Bernardo, Renato, Amy, Ken, and thanks, Chuck, for your incredible facilitating role as well. A couple of departing announcements. We do have a few additional questions that we will forward to speakers, and we'll get some answers and distribute back via the Whova application. We're now going to transition to our work group meetings, which will begin at 12 noon, just about now. I see we have about 10 or so work group meetings starting now for our next concurrent, and they will be concurrently going through our next 90 minutes. And then other sessions will also start along the remaining of the afternoon in US time. So please do follow the entire work group meeting agenda on the Whova app for details on joining those respective work groups. Also, I wanted to very quickly mention a number of networking events being convened throughout the week. We have country meetups, regional meetups like the Hl7 Europe. We have our first-time attendees meet and greet. We also have exhibitor showcases, and don't forget our cookie break meetups as well. To link to any of these activities, networking activities, please do go to the community link at the bottom of the Whova app main screen. And lastly, just one word, looking very much forward to seeing you again at the Wednesday annual business meeting and our second plenary, where we will have some important Hl7 international announcements to be made then. So thank you again. We're going to now transition to our workgroup meetings. Have a wonderful rest of the week and much success in all the working group events coming up. Thank you so much.